Evening all. Big night tonight, 6:32, and it's an early one tonight. This will go down in history. What? No. Oh God, sorry. Just trying to phone emergency because I'm pressing the off button. Big match tonight, England v Wales. Right then, come on. So I've only got the Welsh. I haven't got an English flag. I've only got a Welsh flag. So we're going to get this done, but got quite a few questions, which is always good. Actually, what's happened here? So if you do have a question, then don't let it stop you. I will see this through to the bitter end, and I will stay. But I imagine people are interested in watching the World Cup, but I don't know. Maybe they're not. I spelled my name wrong. Staiano. Plastic surgeon. So, hoping everything's working. Is the audio working? Follow and unmute. I say unmute. Wouldn't be the first time that I have. Oh, that's a bit wonky, isn't it? Oh, my tripod's broken, so I'm trying to. Hello. Oh, hello, Instagram. Oh, how do I do it? Corin's here. I'm going to wave, but that is dodgy. Right, guys, let's get this done. Yeah, that's a new thing. Follow and unmute, it says there. So follow and unmute on Instagram. Can you follow? Yeah, of course you can follow. Hi, Jackie. Nice to see you again. Still here. Let me get rid of that. So if you've got any questions, I will ask them. Can I just assume the audio is working on Facebook? I'm assuming the audio's, you can hear me. Oh, flip. Oh, dear. This is unstable. It's unstable. Oh, God. Instagram is unstable. Okay, let's do this. First question, no messing about. Yes, Doc, we can. Thank you, Julie. There is someone on Facebook, and Julie is living proof of that. So, can I have a lipoma removed under general anesthetic? Oh, sorry. And again, what? Can I have a lipoma removed under general anesthetic if I have ehlers-danlos syndrome? So, in general, I think the general answer to these sorts of questions is we always check with the person who's looking after your problem. Ehlers-danlos, I'm putting that low. Ehlers-danlos is a, I need a bit of blue tack, is a connective tissue disorder which is gives skin elasticity. So people can do that, and they have hyperelastic joints and things, and it does reduce your ability to heal wounds. So you're going to have an increased risk of wound healing problems with Ehlers-danlos. So it will increase your risks, but it's not an absolute contraindication. So you have absolute contraindications. I'm going to get to one later on, and you have relative ones. So I would say it's a relative one that it would increase your risk of wound healing problems. Now, usually with lipomas, we're just cutting skin, make an incision in the skin, and then the lipoma is underneath the skin. So there's no tension. I'm not sure what microphone this is supposed to be. So there's no tension on the skin. So wound healing usually isn't a big deal. I guess, I mean, you're saying a lipoma under general anesthetic. That makes me think it's a big one because we tend to remove small lipomas under local anesthetic. But anyway, in general terms, Ehlers-danlos is not an absolute contraindication. But as I say, we'd have to discuss with you the risk of increased wound healing problems. So it will be a balancing that risk versus the benefits of removing the lipoma. I have an uncoloured mole on the side of the bridge of my nose, and I was wondering if removal is possible due to its tricky position. I'm worried about the resulting scar and curious about my options. So I don't think I have seen a photo of this one, but an uncoloured mole is usually what would be usually intradermal nevi, which are they're usually raised, because if it was an uncoloured flat mole, that would be that wouldn't be a mole, would it? That would be like a piece of skin. So they're usually raised. I'm going to wave at you, Ali. Oh, difficult. I'm worried the phone's going to fall. And they're usually raised, and so benign intradermal nevi. And so often with raised benign lesions, we can do shave excisions. So it really doesn't matter where it is, to be honest with you, because a shave excision just leaves a wound, a graze the size of the base. If you have to cut it out, then you're absolutely right. The nose is a tricky position. What are you saying? On my nose, on the side of the bridge of my nose. So bridge of my nose here, side here. So that's the canthus. So you're absolutely right. That's a tricky position. You've got to be careful with the eyelid. You don't want to put tension on the eyelid. There's not a huge amount of spare skin. Same here on the alar, the sort of rim of the nose here. These are tricky positions. So if we have to cut them out, then that's a little bit more difficult because it might distort the anatomy if we're cutting out big moles in those areas. If we can do shave excisions, then it doesn't distort the anatomy quite so much and is less tricky. So if it's a raised, uncolored, benign thing, then it would be fine. If it was colored, then we would worry the pigment will go deeper than the level of the shave, and if we were worried it wasn't benign, then we would have to excise it. So that would make it a little bit more difficult. So bottom line is probably all right. Yeah, in a nutshell. Can I have a tummy tuck if I have type 1 diabetes? Bit like the ehlers danlos. It's a relative contraindication, not an absolute one. So the simple answer is yes, you can, but it does make life a little bit more tricky because we have to be a little bit careful with your sugar in terms of during the surgery and after the surgery, because you'll be starved and what have you. So we have to be a bit mindful of that. And the other thing we need to be careful of is the fact that you will have an increased risk of infection, because diabetics have an increased risk of infections. So that is going to be something that you would have to be aware of, and again balance those risks with the benefits. And the other thing we need to make sure is your diabetes is stable. So if your diabetes isn't stable, if your medication's being changed, then we would probably say, let's hold off until it's a little bit more stable. Ali has got a question here, or at least a statement. Tribal marks. What are you saying, Ali? Talk to me. Expand on that. You got tribal marks, you want them removed? Are we talking about things on your face, or is it you asking for a friend? What is tribal mark? So if you could expand on that, that'd be helpful. Amy has got a question here. What you got, Amy? I have lost 9 stone. I have had 360 tummy tuck, but still feel like I have loose skin above my belly button. Been told I could have a reverse tummy tuck, or should I have had a FDL? FDL doesn't. No, I don't necessarily think maybe you shouldn't have had an FDL. Sometimes you do have loose skin above your belly button after a tummy tuck. A reverse tummy tuck's quite a big deal, Amy. I'll be honest with you. It would have to, but yes, that is the best way to directly address that skin of the upper abdomen. A normal tummy tuck or a sort of full or a circumferential tummy tuck doesn't really directly excise skin from above the abdomen, but it pulls it down. So it normally does benefit it to some degree, but there may well still be loose skin and you may need that addressed later on. And probably the best way to address it is with a reverse abdominoplasty. A fleur-de-lis abdominoplasty will take the skin from a side-to-side direction. So it's really going for the waist. It's going for the side-to-side rather than that skin underneath your breast. So I'm envisaging a situation of a sort of fold, if you like, of skin underneath your breast in your upper abdomen. That would be a good candidate for a reverse abdominoplasty. You could consider liposuction if it's not really a proper fold of skin and just a bit of fullness. So sometimes that helps if there's a bit of fullness in the upper abdomen after a tummy tuck. Liposuction might help, but if it is, loose skin, I would say the best way to address it is by reverse abdominoplasty, which gives a horizontal scar and it pulls that skin up tight. A fleur-de-lis abdominoplasty would have given you an extra vertical scar. So the vertical scar will allow you to tighten in a side-to-side direction. But it sounds like your problem is underneath your breast, upper abdomen, up, down. If you were sort of demonstrating to someone what you want, you'd probably pinch it like that rather than pinching like that. Anyway, it's an option. You could convert to a fleur-de-lis and have a horizontal, a vertical excision, but probably a reverse abdominoplasty is probably if it is significant. And if you've had a 360 tummy tuck, I'm assuming you have a significant excess, because that's quite a big op. So reverse would be the way to go. Tribal marks. I have tribal marks in my forehead. Yeah. Okay. So you want them removed. So the thing I always say to people, Ali, about removing tribal marks, basically scars, removing scars, is that no one can remove scars. We can only make scars different. So if there is something specific about the tribal marks, then maybe we can help in terms of the fact if they're a bit wide, if they're going in a bad direction. Excuse me, on the forehead will be like this sort of direction. We try and do it in the lines of where you have where you get wrinkles, which are going like that. So if it's not going like that, then that'll be bad. Centrally, you can have lines going like that, but up there. So we could always change the direction of it if the direction wasn't good. If they're raised, if they're dented, there may be things we can do to help them, but we won't be able to remove them. So we might be able to change them if there's a specific problem that we can address, but we won't be able to remove them. So it's something to have to be aware of prior to going down the route. If you want, Ali, you can always email a photo to me, and we can give you an idea of what could be possible if you would had to have something done. Amy, you are very welcome. Excuse I. I have lost 15 stone, but I still have a BMI of 36. Would you perform a tummy tuck? Good one, this. Because this is a patient I actually spoke to on the phone the other day, and because they've been turned down by at least one, maybe a couple of surgeons, and I think / hospitals, and I think they're not unreasonable to turn them down. Really, it sounds awful, but they what I try and say is they're working on your behalf. They're not working to try and mess up your life or make life difficult for you. They are trying to help, but because the risk of complications is higher with a higher BMI, and we normally look at a BMI of 30, so 36 is quite a bit more than 30, and that would increase your risks in terms of wound healing problems, chest infections, DVTs, PEs, all sorts of complications. Also increases your risk of a poor cosmetic outcome, because if you still have intra-abdominal fat, you can have a barrel-shaped abdomen at the end of the surgery. Even once you've had a tummy tuck, your tummy can still look barrel-shaped. We'll get rid of the apron, but if you've got fat inside your abdominal cavity with your stomach and what have you, then we won't remove that. So you sometimes still can look quite big, even after a tummy tuck. So these are all discussions we have to have preoperatively. And for me, it's not a flat no. I totally understand a lot of people do have flat nose above 30 or even 27, some people, and I completely understand that. And there is nothing wrong with that. And that's the safe way to operate. But I think some people will never get there. And I do also think, in this situation where you've lost 15 stone, let's not forget that 15 stone is a huge amount. And also you're comfortable being that weight. You don't particularly want to be a lot lighter. So, as long as you can understand the risks associated with surgery and exactly what will be done with the surgery, that apron of skin will be removed, but you might still look big. That might be an option. So it's not a flat no, but it's a totally understand why people are flat knowing it. But I would always talk to you about it, and we hopefully come to an agreement between us rather than you asking me for something and me saying yes or no. I have a cyst on my scalp, which has been present for a few years, but I've recently had a hair transplant. Will this be suitable for cyst removal? Yes, you will. The only problem with doing a cyst removal on the scalp is that it'll leave a scar. So cyst removal will leave a scar. And the problem when you haven't got much hair, I wouldn't know personally, but if you haven't got much hair, if your hair's sort of short cropped, if you have a scar, you get like a defect in the hair, and it's a little bit more obvious if you've got short cropped hair. So if you've had a hair transplant and maybe it's all working fine and you've got a shock of hair and it looks fantastic, then that's great, and your scar will be hidden. You won't see it, assuming it's quite far back in your hairline. However, if you were to lose your hair in the future, or if you are thinning at the moment, then a scar can be a bit more obvious. So paradoxically, a scar can actually look quite good on someone who's completely shaved their scalp because it's just like a white line, or someone who's got loads of hair because it's hidden in the hair. The worst sort of thing for a scar is having short cropped crew cut, sort of buzz cut, because then you see a defect in that. Same with the beard. big massive beard, a scar will get lost in it. Clean shaven, the scar can often just look like normal skin, but actually with a short cropped, trendy George Michael type beard like myself, it can look a bit obvious with a defect in the hair. So that's something to be aware of. So will I be suitable for cyst removal? Yes, probably yes. I haven't seen you or your cyst, but you have to be aware that the scar might be a bit more obvious. Some good questions today. Would you offer exchange of implants and mastopexy if I have Brugada syndrome? I've got to be honest, I had to Google this. And I Googled it just tonight because I know that this has been dealt with, because the answer is always we would talk to the anaesthetist and potentially talk to the doctor looking after your problem. Now, Brugada syndrome is a cardiac condition, it's a heart condition, and the anaesthetist has actually already said no. They would not do an anesthetic on you. So, and again, a bit like the BMI thing, we're trying to work with you here. We're not trying to be unhelpful. It's just because the risks are too great because of your cardiac condition. So this would be in this circumstance an absolute contraindication to surgery because the risks are deemed to be too great. It's interesting that you're asking for exchange of implants and mastopexy. That assuming you've had implants put in, and I wonder if you had your Brugada syndrome when you had the implants put in. But that's a separate point, because the anaesthetists in the hospitals that we work at have said that they feel the risk is too high. So I'm sorry about that. That is an absolute contraindication. That is a no to that one. What is 360 liposuction? Yeah, a lot of people ask for 360 liposuction, and I throw it back and I say, look, what do you mean by 360 liposuction? And I think sometimes people say, well, I don't know, I just saw it on Instagram and I saw it in a 360 liposuction look really good. And I'm like, well, by the nature of it, I'm assuming they're talking about doing liposuction all the way around, and maybe as a sole procedure, maybe under local sedation, maybe that's okay if you're kind of breathing for yourself. But most of the times I do liposuction to the trunk, I'm doing it with a tummy tuck. So it's rare to do just liposuction in my practice. I do it with a tummy tuck. So if I'm doing a tummy tuck, that's usually under a general anesthetic, which means you get put to sleep. And it's actually quite a big deal to turn you when you're asleep, when you're under anesthetic. It's the anaesthetists don't particularly like it. And so I don't turn people, and I don't get right round to the back. So when I do liposuction, or when I'm doing a tummy tuck, I do it to the hips and flanks, hips being this area here, flanks being that. So where my hands are, yeah, that's where I do it. I don't do it, I don't get round the back there. So yeah, I don't do 360 liposuction. I just do hips and flanks. I get as far as I can while you're lying on an operating table. What is? I think I asked the question. What is when Amy said to me, someone wants 360? I said, what do they mean by it? So that's what I think I don't use the term because I don't particularly do it. I just do hips and flanks. I don't go all the way around to the back. It's unusual to have a problem with the back, not unheard of, unusual. And again, I guess it's not 100% no. You can turn during a tummy tuck because we do 360 tummy tucks, so you can turn, but it just increases the risks. And usually, the main benefit comes from the hips and flanks rather than right over the sort of back and the midline of the back. I have lipoedema. My BMI is 68. Can I have a tummy tuck? No, I wouldn't do that. Again, I think we had a 36, and I was sort of talking about it. Is that right? BMI 68. Yeah, I wouldn't. I think the risks of doing a tummy tuck on you with a BMI 68, that would be quite a niche thing, and a niche doctor that would look after that, and I'm not that doctor. So I think BMI 68 is too high for a tummy tuck, unfortunately. I'm afraid. What do you think about liposuction on lower legs, knees, calves, ankles? Do you do it at your clinic? What do you think about liposuction on lower legs? Do you know a good doctor? How would I find a good doctor to do it? Yeah, well, the second part of the question is sort of answered the first part. I don't really do knees, calves, ankles. Sometimes some people have a sort of a specific bulge just around the knee, but calves and ankles, no, I can't. I get. It's surprising how often people ask for it, actually. And I understand that some people don't like the shapes of their calves and their ankles and want them to be contoured, but I can't really give a good result with liposuction. I think the amount of subcutaneous fat in that area is so small that if you were to there's a risk of overdoing it and causing contour irregularities and making it look odd, and it's not really something that I would do personally. And I don't know a doctor who does it, to be quite honest with you. Probably there are, but I don't know one. I really don't. Can I have a tummy tuck if I have an ileostomy? Again, easy answer would be no. I would say that would, kind of be an absolute contraindication, an ileostomy. I mean, never say never, and you have to talk about a case by case basis, but probably you'd have to have the ileostomy recited, so you'd have to have a general surgeon in theatre to put the ileostomy. Once you've done the tummy tuck, to put the ileostomy in a new piece of skin from the tummy tuck. It's just adding a level of complexity that I would say would be too much, personally. So I would say the easy answer is no. Could it technically be done? Well, yes, it could technically be done, but I think most people would be of the view that they would be less likely to do it in someone with a tummy tuck. So I would say, for me, that's probably going to be talking about an absolute contraindication, an ileostomy. Happy to talk to you about it. Well, I am. But I would say, generally speaking, no. Gabrielle Rebecca, can you do anything with the chest bone between the cleavage? No. So presumably this is there's two problems that people get with the chest bone bleeding between the cleavage. It's either too prominent or sort of indented. So it's called pectus excavatum or pectus carinatum. So excavatum is the sort of dent, and carinatum is the sort of bowing out. And if you have a chest wall deformity in that regard, then the answer is to go and see a thoracic surgeon, so a specific surgeon who would look at the bony structure of your chest, and they could do bony surgery to correct that. That might be an option. And certainly if you're thinking of having breast implants, I don't know why I'm assuming you are, but that's just because that's most of the people I talk to are. If you are assuming if you are thinking of having breast implants, it's always best to look at potentially getting your chest wall deformity fixed first. There are situations where plastic surgeons do fix chest wall deformities in terms of the excavatum, where there's a dent, in that you can get a custom-made implant. They can do an MRI and make a custom implant to fill the chest wall defect, which is in some ways easier surgery with less risks than the actual bony surgery. But this would have to be discussed. That's something that could potentially be done on the NHS. I'd imagine it'd be quite expensive to do that privately. I'm not sure whether the NHS would do it or not, but they certainly did when I was there, getting that sort of thing fixed. And you'd have to look at getting that fixed first. If you didn't get that fixed and you were considering implants, you could still consider implants. But if you have a chest wall deformity, sometimes the breasts problems with the breast can be accentuated. So for instance, if you've got a prominent rib cage and your breast is pointing a little bit laterally, if you have them augmented, they can look like they're pointing even more laterally. So it can accentuate that defect. So that's something to be discussed preoperatively. Sometimes having a breast augmentation can take the eye away from a chest wall deformity between the cleavage. So it might make things less obvious, but it's something that needs careful discussion. And it's great that you're bringing up the question before. You want to bring up that question before surgery rather than after surgery, having implants or whatever, and saying, what about this? You haven't done that. So it's good to talk about that. Oh, here we go. Now I'm going to jump Sarah, because I'm not going to jump Sarah. I'm going to jump over the question. NHS won't touch me. I need to go private because it's not severe. Just no idea where to turn. If it's specifically your rib, the chest bone between the cleavage that's the problem, Gabrielle, I would say a thoracic surgeon. So there are thoracic surgeons. Everyone's got specialized. Used to be cardiothoracic. Now there's cardiac and thoracic. So a thoracic surgeon would be someone to have to talk to. Your GP might be able to refer you to a private surgeon. If you are asking the question in the context of wanting breast implants, then, as I say, sometimes breast implants can help to make the problem less obvious. Sometimes they can make it more obvious, as I say, if there's a tilt in the shape of the breast. So you could talk to a plastic surgeon, but where you find one privately, GP, well, either GP or local private hospital. If you live near a Nuffield or a Circle or a BMI, I think BMI is bought by Circle, or Spire or Ramsey or one of the big hospital groups, then they will have cardiac surgery. Well, are you Birmingham? If you're Birmingham, the Priory, basically. If you're Birmingham, Gabrielle, the Priory in Edgbaston in Birmingham, just give the Priory a ring, and they will have thoracic surgeons there who will be able to give you some advice onto, they exist and they're there, Gabrielle. That's what I would do, or your GP. But good luck with that, Gabrielle. But yeah, don't despair. There are doctors out there who treat that sort of thing. Sarah, what you got? Hello, can a seroma leave a bump or saggy skin where it was, as I had a large seroma but it's gone, but where it was is not flat before I had the seroma? To a degree, certainly if it's been there a long time, Sarah, but I wouldn't lose hope because it might retract. It might get better. It might retract in time. So I wouldn't write it off. Well, I don't know, unless it was ages ago that you had it drained, but it will stretch the skin to a degree, but it usually will, and it might be that there's a bit of seroma there. That's why you've got, why not be fat, because there's often flat, because there's often a bit of residual seroma which will then get better on its own. So if it's not that long ago that you had it drained, then don't lose hope. There might be a bit of swelling, bit of seroma still there, a bit of spare skin, which just takes time to retract. So it should hopefully it'll get better. Christopher Frank, I'm not sure. May granddaughter have super morbidly obese wife have done. Is that another language, Christian, or is that your autocorrect? Not understanding that one. Gabrielle, I do want implants. Yeah, I've been told it might not be a good idea though. No idea why. What does it say, Gabrielle? If you have a tilt to your chest wall and you've got small breasts, that might not be very obvious. But if your breasts if you have breast implants and they're enlarged, the tilt might look worse, like a ship that slightly veers course, and then a couple of degrees off course. If it's not gone far, it doesn't look bad. But when it's gone far, it starts veering further and further off course. I'm not sure if that's a good analogy, but basically, if your chest wall's tilted, augmentation can make that tilt look more obvious. So that's why I think they're saying it might not be a good idea. So it's tilted either way. So it is something that you need to have a think about prior to having implants. My ship might sink. Yeah, your ship won't sink, Gabrielle. It'll go too far off course. That's the thing. What's going on? Why are people joining now? We've got the football on in a minute, right? Shit won't sing, Gabrielle, but it might accentuate the defect having implants. Is that all right? Come on, England, he says with a Welsh flag. Come on. Right, let's go and watch the footy, shall we? Let's go. Any more? Is that all right, Gabrielle? Good luck with that, Gabrielle. And if you Birmingham, check out the Priory. Thanks, JJ. Enjoy the match. See you tomorrow at 5. I was going to say tomorrow. See you tomorrow, Corinne. Looking forward to it. And I'm going to check myself out. And love you lots.